Devi Ram, 67-year-old male with a history of hypertension on ATT for fever and pleural effusion. He presented with nephrotic syndrome. So clinical diagnosis was membranous nephropathy, adult onset MCD or FSGS. So this was adequate biopsy. So you can see the core which is lying above, that is showing predominantly medulla. Why I say it is medulla? Because I can't see any glomeruli here. But the core which is seen down, it is showing good number of glomeruli. Okay. So this is from the cortex and this is from the renal medulla. So when you see a lot of tissue from the renal medulla, there is always a history which will come that this patient had hematuria after the biopsy. I hope this patient didn't had any hematuria. There was good amount of medulla also, which was there in this biopsy. So if you look at the glomeruli, this is just to highlight that many times we know that glomerulus has got a hilar pole and a tubular pole, but when you look at the kidney biopsy cross sections, there will be an occasional cross section where you will be able to visualize both the hilum as well as the tubular pole. Okay, so in this glomerulus, what you can see is this is the vessel. So this is a hilar pole, and this Bowman's capsule is continuing with the tubule. So this is the tubular pole of the glomerulus. So in this glomerulus, you can see the hilar pole, and diagonally opposite, you can see the tubular pole. So when we say there is a segmental sclerosis near the tubular pole, that is labeled as a TIF variant of FSGS. Okay. And TIF variant of FSGS is a very good variant and it behaves like minimal change disease. So in this case, there was a segmental sclerosis which was lying here. This glomerulus is showing a segmental lesion. This glomerulus is absolutely fine. The capillary loops are patent. There is no evidence of any endocapillary proliferation. Even in the urinary space, there is no proliferation. That means no crescent formation also. And this glomerulus is showing a segmental lesion. I'll show a higher magnification of the same. Otherwise, the tubules look fine, except for maybe an occasional few tubules showing a very minimal kind of patchy, some tubular dilatation and all that, but no significant tubular injury as such. So this is just to highlight that there is a hilar pole and this is a tubular pole of the glomerulus. You can see that. So this is a vessel, this is the renal hilum here, and these are the capillary loops, and this is the Bowman's capsule, and this is a parietal epithelial cells which is next to the Bowman's capsule, and this Bowman's capsule continues with the proximal tubule here. So this is a tubular pole. And this is the glomerulus which is showing pathology in form of segmental sclerosis. Now this segmental sclerosis is near the tubular pole. So it is near the tubular pole of the glomerulus. I don't know whether I labeled this as a TIF variant of FSGS, but this lesion looks like a TIF variant. Okay. This is another view. In this, I can't appreciate whether there is hilum or there is tubular pole. So when I'm not able to visualize the tubular pole in a glomerulus, it is impossible for me to label that as a TIF variant of FSGS. I will label that as FSGS NOS. So there are practically there are four types of FSGS what we look at. So FSGS TIF variant, which I've told you. So when we see such case of collapsing variant, I'll show you that case also. So when there is a collapsing FSGS and there is a tip lesion, both are there, we label that as a collapsing FSGS because that is more aggressive form of FSGS. Cellular variant of FSGS, there is a lot of subjectivity among the renal pathologists among how to diagnose this cellular variant. But they say when you see endocapillary hypercellularity in form of endothelial cell proliferation, or you see endocapillary foam cells, or you see some inflammatory cells, then you label that as a cellular variant provided the immunofluorescence is negative. So in this case, this was a FSGS TIF variant, and it is very common that you get to see IgM non-specific trapping. So you see this glomerulus, this is absolutely negative, and suddenly you see a bright staining at one end. And this kind of a thing can happen because whenever there is a segmental sclerosis, there will be non-specific plasma proteins which get deposited there. And these plasma proteins will take up the IgM or the C3 state. So there will be non-specific IgM C3 trapping. Many times when you are early in your career in renal pathology, or you are not a trained renal pathologist, then you will interpret them as positive staining, but actually it is a non-specific trapping. Or this is just to highlight that how a normal ultrastructure morphology of a globulus looks like. So this is the normal ultrastructure image of a globulus, electron microscopic image. You can see this is the Bowman's capsule. The cell which is adherent to the Bowman's capsule is a parietal epithelial cell. This empty space is a urinary space. This is one capillary loop. So this you can follow this capillary loop from here to here. So this is the inside of the capillary loop. Okay, and this area is the mesangial area. So this is the inside area of the capillary loop. So you can see this is endothelial cells, and if you look outside the capillary loops, these are foot processes. So you can see absolutely preserved foot processes here. Okay, this D highlights the foot processes, E highlights the urinary space, B is the endocapillary space. So inside the capillary loop, A is the endothelial cell, and what is C? The C is outside the capillary loop. So this is the podocyte nucleus. So podocyte is like an octopus. Okay, it will send multiple processes, which will one podocyte can cover numerous number of capillary loops. So it sends and what are these food processes? These are the cytoplasmic projections of podocyte. So you can see a single podocytic nucleus, and it has got these cytoplasmic projections, which are food processes. And you can see these food processes, the single podocyte is covering one capillary loop here, a second capillary loop here. Okay, and in our present case, so what you're seeing here is this is inside of the capillary loop. This is outside podocyte cytoplasm, and you see these vacuolizations. So whenever you see vacuolization within the podocyte cytoplasm, that means this patient has proteinuric state. And these are the endothelial cells. And the important thing is there is diffuse food process effacement. You don't see any projections. So complete or diffuse food process effacement is there. So there is a percentage based on which we say if there is a focal or a diffuse food process effacement, because it was seen that sometimes you label anything as a focal food process effacement. What is the percentage of food processes which are faced, whether it is 20%, 30%, 40%? So it is said that if it is more than 80% food process effacement, then only you label that as a diffuse podocytic food process effacement. And when there is a diffuse podocytic food process effacement, it is consistent with a primary podocytopathy. One important thing I want to tell you, if in a biopsy there are maybe 10 glomuli, and in those 10 glomuli, I see absolutely normal glomerular morphology. Okay, still the diagnosis could be two. It could, and if this patient has nephrotic syndrome, so there will be only two diagnoses. One is a minimal change disease if immunofluorescence is negative, and the second thing is unsampled FSGS. Since I am visualizing only 10 glomuli, it is possible that you can miss on the segmental sclerosis lesion. On the other hand, if there are maybe 25 glomuli in a kidney biopsy, which is not a very common finding, you when you look at the kidney biopsy, you normally get 10 to 12 glomuli. So if there are 25 glomuli, uh, and in those 25 glomuli, there is no segmental sclerosis lesion, and immunofluorescence is negative. Electron microscopy showed diffuse food process effacement. The chances that this is going to be MCD are more likely, and the chance of missing a segmental sclerosis lesion is less likely because the number of glomuli are more which you are visualizing. So you have to remember one important thing. When in electron microscopy, I say there is a diffuse podocytic food process effacement. If there is a segmental lesion in the light microscopy, I label that as a primary FSGS or a primary podocytopathy. If there are 25 glomuli with the normal morphology, I see diffuse food process effacement, negative IF, I label that as a minimal change disease. So what I want to highlight is electron microscopy is not going to differentiate FSGS from minimal change disease, because both the disease pathologies will show diffuse podocytic food process effacement. There are few articles which state that there is a podocytic detachment in FSGS, which you don't get to see in minimal change disease. But that is very difficult to interpret. That is a very subjective kind of thing. Someone may say, so in this case, I may say that I can't see any podocyte nucleus, so this is most likely there is a podocyte detachment. But that is not a correct thing, and that is the reason that the main the pathological difference or the basic pathological processes or idiopathic or whatever you can say, the main pathology behind differentiating MCD and FSGS is the FSGS thing. Why we label that as podocytopathy is because there is a reduction in the podocyte number, whereas in minimal change disease it is only the functional problem. That means there is the number is normal of podocytes in minimal change disease, but there is a functional abnormality. The functional abnormality is the podocyte food processes are faced. That is the only difference. Okay, but on morphology on EM we can't differentiate. So since I was seeing FSGS lesion on the light microscopy and there was a diffuse photocytic photoprocess effacement, I label this as a primary FSGS. So EM plays a significant role whenever we come across segmental sclerosis lesion, because many times we see patients long-standing hypertension with FSGS lesion and they are treated like primary FSGS, and in those cases EM was not done. If we would have done EM in those cases, we would have seen that there is no diffuse or significant foot process effacement, and that would have been labeled as a hypertensive nephrosclerosis with secondary FSGS lesion. Okay, ma'am. So we come to the end of this case. Devira. Hello.
Yes, we are there.
Yeah. So, ma'am, treatment-wise, this patient was must be put on steroids and all that.
Yeah, he has responded very well to steroids.
Okay.
So his behavior is like actually minimal. That's what you were saying.
Yeah. Okay. Okay. So, so that is a likely possibility because I have shown you a stiff variant of FSGS also. So that behaves like a MCD. So it is possible that his behavior should be like MCD only. But many times, ma'am, I see biopsies. That is why I stop labeling them as minimal change disease categorically. If I see normal glomerular morphology and if I see 10 or 12 glomeruli, because I used to label them as minimal change disease, and then the response will come after 2 weeks of steroid therapy or maybe 3 weeks of steroid therapy, there is no response. So this patient is not behaving like MCD. So actually the steroid response will tell you whether this patient is behaving like MCD or FSGS. So so that's why I label it as a normal glomerular morphology, and I give two possibilities: either a minimal change disease or unsampled FSGS correlate with the steroid response.
That's okay, pretty standard.
Yeah. So we come to the second case. This is Pramila. So Pramila is 52-year female with hypertension for 15 days, presented with nephrotic syndrome. Urine PCR was 3.5 grams, serum creatinine was 1.6 milligram, and serum albumin was 2.3. So in this case also you can see a segmental sclerosis. So sometimes what happens is in a glomerulus there will be segmental sclerosis lesion, and since this segmental sclerosis lesion, why I say segmental sclerosis, because you just see these capillary loops which are patent, empty looking capillary loops, and suddenly in this area and in this area you see that there is only in this area you can see some patent kind of capillary loop, but in these areas it is lost. So that is called a segmental sclerosis. And whenever there is a segmental sclerosis, there will be some adherence to the Bowman's capsule. And the Bowman's capsule parietal epithelial cells also react to this segmental lesion or segmental adhesion. So there will be some parietal cell proliferation. So initial when maybe a renal pathologist early in his career, he looks at these lesions, he may interpret these as small crescents also, because there is some parietal epithelial cell proliferation. So any segmental sclerosis lesion will produce some reaction, some podocyte proliferation, or not a podocyte proliferation, some parietal cell proliferation. Only a collapsing lesion of FSGS produces more significant podocyte hypercellularity or podocyte proliferation. Okay. So in this case, there was some parietal epithelial cell reaction because this segmental lesion was getting adhered to this Bowman's capsule. So this is another magnification to highlight that you can appreciate that these are the capillary loops which are absolutely empty, and suddenly you see this area where there, and these are the parietal epithelial cells which are there. Similarly, you can see this area. This is not very clear. The section is not clear, but in this area you can see that there is some adhesion and all that stuff. So there were few tubules which are showing. This is the PS stain. So I just want to highlight that the tubular brush border is well seen in a PS stain. So this is under oil immersion, and suddenly you can see this border, this brush border. This is disrupted in this area. So that means there is a tubular. This patient had some rise in serum creatinine also, which was like 1.6. So there was some tubular injury. So you can see a brush border here, and then there is a disruption of brush border here. Again, a slight brush border, again a disruption, again a slight brush border, and here it is pretty continuous. Here also there is some disruption. So there is some disruption of the brush border. Otherwise, the tubules are back to back. There is no interstitial edema. There is no separation of the tubule. So this can happen in a mild kind of tubular injury where there will be loss of only or a disruption of the brush border. So which was seen in this case. The other thing I want to highlight is the tubules, whenever there is a nephrotic state, Or sometimes in a ATN also you see some vacuolization, and at places these vacuolization looks like isometric vacuolizations also. Okay, so we face this problem in transplant biopsy more, because transplant biopsy sometimes you see these vague isometric vacuolization which are actually not vacuolizations of CNA toxicity. So it is also, vacuolization is not a very specific finding, but yes, sometimes classical isometric vacuolizations are seen. That is okay for CNA, but otherwise some vague vacuolizations can be seen in any nephrotic state in tubules, in any form of tubular injury which is unrelated to CNIs. Okay, and non-isometric vacuolizations, many times I write in my report also, non-isometric vacuolizations you see commonly in electrolyte imbalances, mannitol fusions and all that. Osmotic diuresis, you can find those. So there was some kind of a vague vacuolization. There was a tubular injury which was mild, and there was a segmental sclerosis. And electron microscopy showed that, so these are the this is a endothelial cells. This is inside part of the capillary loop, so there is an endothelial cell. Okay, and yes, so this is endothelial cell, and these are the, this outside, this is a urinary space. So in this, you can see the cytoplasmic vacuolization. That means there is a proteinuria which is going on. But where are the food processes? They are gone. So there is complete food process or diffuse food process effacement. So many times when there is a diffuse food process effacement, there will be actin protein, actin cytoskeleton protein, skeletal protein, which gets deposited on the GBM. Okay, and many times since these are dark colored proteins, you interpret them as subepithelial deposits, or in other form, subepithelial deposit means membranous. So you interpret them as, possibly it is MGM. But the thing is, immunofluorescence is going to help you. If immunofluorescence is negative, you know that it is not membranous. So what I want to tell you is, whenever there is a diffuse food process effacement, there will be some actin protein condensation. So this is actually actin protein condensation and not subepithelial deposits. Okay. So this is for the pathologist to know about. But yes, many times I've seen that it is MCD or FSGS with the diffuse food process effacement. This actin condensation being interpreted as subepithelial deposit, which is not correct. But yes, immunofluorescence is going
Rajan,
to.
there's something on the endothelial surface also.
So, ma'am, so this side. So when you look at this side, so there are some
Right.
dark color things,
Yeah.
ma'am.
What's that?
Ma'am, many times these are artifacts. Okay, ma'am. So so the thing is, if it is not an artifact, that can happen in fibrin. Fibrin can also produce this kind of a dark color structures. But ma'am, when there is fibrin, there will be history of malignant kind of hypertension, and on morphology also I'll find something of a thrombotic microangiopathy kind of a finding and all that. So these kind of, many times in electron microscopy you see certain things which are actually processing artifact rather than true pathologies. So this, the true pathology is, there is a diffuse podocytic effacement, there is a cytoplasmic vacuolization in the podocyte cytoplasm, and we are seeing a segmental sclerosis lesion with the light microscopy. Immunofluorescence was showing again a non-specific IgM-C3 trapping. So it is also consistent with the primary FSGS. The only additional finding is there is a tubular injury also, which is seen in this case. So this was FSGS with ATN. So we come to the next case, ma'am. This is Zayed Mohammed. So this was 33-year-old male. He is a known alcoholic, presented with nephrotic syndrome, dialysis dependent. Serum albumin was 1.6, total protein was 4.3, C3, C4 was normal, urine ACR was 3.9 grams, query MGN with AKR or MCD with AKR. So what we can see here is, there are some tubules which are showing some separation. So that means there is some edema which is there, and these tubules are dilated also. Look at this tubule. This is, so there are some tubules which show some cystic kind of dilatation, and that can happen when there is a acute tubular injury. The glomeruli, this is a pH chain which shows that the glomerulus is absolutely normal. The capillary loops are fine. There is no thickening of the capillary wall. There is no endocapillary proliferation. There is no extra capillary proliferation. And the tubules, you can see some separation. Majority of the tubules are back to back, but there is some separation of the tubules. And I'll show high magnification of these tubules. So you can see that you can appreciate the tubular nuclei here. And suddenly there is complete loss of tubular nuclei in this area. And you can see the cytoplasmic or the tubular brush border, which is like dislodged and is seen in the tubular lumen. So this, all these findings are consistent with the tubular injury. So there is a diffuse ATN in this, and along with that, there is absolutely normal globular morphology. So when we see normal globular morphology, immunofluorescence is completely negative, and you see diffuse podocytic foot versus effacement. So this is again the cytoplasmic vacuolization of the podocytes, and you can see the endothelial aspect is fine. So this is the endothelial aspect. This is towards a urinary space. So this is the podocyte cytoplasm, diffuse podocytic foot versus effacement. So the diagnosis is minimal change disease. So this was MCT with ATN. It is said that MCT with ATN, these patients, they remain dialysis dependent. And what is the prognosis? Do they behave in an aggressive manner as compared to routine MCT cases? In
This
MCT
guy
with
was
ATN?
also taking NSAIDs. So the ATN
Okay.
recovered, his creatinine had come back to normal.
Okay, ma'am.
He was initially dialysis dependent, and even his minimal change responded to steroids.
Okay. Okay. Fine. So we come to the next case, Manju Devi. Manju Devi is 37-year-old female who presented with swelling all over the body for 15 days, history of photosensitivity, joint pains, and small joints of hands. History of tuberculosis 10 years back. Urine routine microscopy showed 3 plus proteins. RBCs were 15 to 20. An impression was lupus nephritis, secondary amyloidosis, or lupus podocytopathy. So clinically, there was a strong suspicion that this is lupus only, which is there because she was fitting all criteria. The dsDNA report was not there, I think, in the form. So I hope the
And it
dsDNA
must
was
have been sent, but it was negative anyway.
that was
Later.
negative. Okay. So this was the normal morphology. So otherwise, tubular incision was absolutely fine, and the glomuli also fairly okay, except for there was some dilatation of the capillary loop, and that happens whenever we see a early membranous. There could be only dilatation. It is I can't say thickening, but there is this the glomerular capillary wall is of the same thickness as the tubular basement membrane, like for comparison this. So based on that, I can say that yes, it could be on morphology. My thought process would have been if this is a clinically SLE with this kind of a normal morphology, there are only two possibilities because I'm not seeing any endocapillary proliferation. I'm not seeing any MPGN pattern. So it is unlikely that this is a proliferative lupus. So either it is if it is a normal glomerular morphology, IF is negative, I'll label that this as a lupus podocytopathy. But if IF shows deposits along the glomerular capillary wall, then it is class 5 lupus nephritis. And both these lupus podocytopathy and class 5 lupus, they will not show any activity in the pathway. There will be no interstitial inflammation. Very unlikely that you in a class 5 lupus will find some interstitial inflammation, but lupus podocytopathy will not show any inflammation. Lupus podocytopathy, the morphology will be like a minimal change disease. It will look like MCT. And there were initially when this lupus podocytopathy terminology was not there, so they used to label lupus with MCT. That kind of a thing was there. Now people have realized that actually it is a lupus which is causing the podocyte injury. So they label it as lupus podocytopathy. So this was a normal morphology or maybe a minimal thickening. IgG was diffuse granular staining along the capillary loops. Okay, so you can see this granularity along the capillary loops. When you look at all the other immunoglobulins and complements, C3 is positive. We have to remember one important thing. In a primary idiopathic membranous, in 90% cases, only IgG will be positive, and C3 will be positive, maybe 2 plus, maybe 3 plus, only in 10% cases, roughly in 10 to 15% cases. So practically, in primary idiopathic membranous, it will be IgG which will be very strong, and C3 will be trace or negative in 80 to 85 to 90% cases. And C3 will be 1 plus 2, 3 plus in 10% to 15% cases. C1q will be negative. Okay. But in class 5 lupus, majority of the patients will have IgG and C3 will also be strong. Okay. And C1q should also be 3 plus. But I must tell you, I did a analysis of class 5 lupus nephritis. There was 60% cases with no full house immunofluorescence pattern. So I'm very sure that maybe 10 years back, the cases which I labeled it as primary idiopathic membranous because we were not doing PLA2R, thrombospondin staining, we were not doing IgG subclasses. I remember there was one case which when I was in Medanta 2011, I labeled that as a idiopathic membranous. And after 3 years, that female came with a recurrent nephrotic syndrome. And this time, again, the immunofluorescence pattern was not showing any C1q staining, but we were having PLA2R and thrombospondin. We were doing IgG subclasses. And then there was a serology also, which was consistent with lupus. So I'm very sure that we are underdiagnosing class 5 membranous and we are labeling them as primary idiopathic membranous. If we are not doing these stains, PLA2R, thrombospondin, IgG subclasses, and now there are new IHCs also, NEL protein and all that. So in this case, C3 was strong. That was an unusual finding. That was more in favor of a secondary. C1q was not strong, but it was like 1 plus, traced to 1 plus. So that was also unusual finding. Then we did IgG subclasses. So when you see multiple IgG subclass staining, that means there was IgG1, which was strong. There was IgG4, which was strong. And there was IgG2 also, which was like 1 plus. So multiple IgG subclass staining. That also commonly occurs in a secondary membranous. And in addition to that, if as compared to if you say in primary membranous, mostly it is IgG4 which will be 3 plus. There could be IgG1 which could be 2 plus, but 2 and 3 will be negative. PLA2 and thrombospondin was done, which was negative in this case. We did EM also. So I remember when we were not doing PLA2 or thrombospondin, we used to discuss a lot of things that we will be able to diagnose lupus on electron microscopy. Because we used to say, if you find mesangial deposits, if you find some subendothelial deposits, it is more in favor of secondary membranous, more in favor of lupus. If you find tubular reticular inclusion in the endothelial cells, it is more in favor of lupus. But with PLA2R, thrombospondin, IgG subclasses coming in, the role of electron microscopy is actually very limited in diagnosing, in differentiating primary and secondary membranous. But in this case also, so I reviewed cases of maybe 50 cases of class 5 lupus nephritis. Mesangial deposits were seen in only 5 cases. Tubular reticular inclusions were seen in only 10 cases out of 50 cases. So it is not that if you find these things, then only you label them as a class 5 lupus nephritis. In this case also, so there were these dark deposits which were seen mostly along the glomerular capillaries. Now there are some unusual findings in these deposits. So I'll show you. So this is a GBM, globular basement membrane. You can see some deposits. This is more towards the subepithelial side, towards the podocyte. This is round structure is a electron dense deposit. Similarly, you can find some round structure here, electron dense slightly. So there is a non-uniform size of these deposits. This deposit is this big, this deposit is like this size. Similarly, here also you can find some deposit like this, and there was some tiny deposit like this. So if you see non-uniform placement of these deposits, that means they are not uniform, because one deposit is here, one deposit is here. It is not like they are uniformly placed. So if they are non-uniform, if they are of non-uniform size, okay, so all these findings are more towards the secondary membranous. In this case, I didn't find any tubular reticular inclusion. So this is another view to highlight that you can see these deposits here. So this is a large deposit here. Then this one deposit is here. So non-uniformly placed, one deposit, small deposit is here. So, and whenever there are subepithelial deposits, you can see foot process effacement. So there is a extensive foot process effacement also that we see commonly in membranous, primary idiopathic, and that we see commonly in lupus also, class 5 lupus also, because when there are subepithelial deposits, you are going to see foot process effacement. So this morphology and everything, though there were no tubular reticular inclusions, but presence of multiple IgG subclasses, PLA2 are thrombospondin negative, all these findings favor a secondary membranous globulopathy. So the terminology also, so some pathologists prefer terminology of membranous globulopathy, some prefer membranous glomerulonephritis. So when we say itis, that means there has to be some inflammation. So the pathologists who favor a terminology of membranous glomerulopathy, they say membranous glomerulopathy we use mostly when we deal with primary idiopathic membranous. And when we say itis, it is when we see some endocapillary proliferation. That means when you are moving towards, when you are going to label that as a secondary membranous, you can use a terminology of itis. And when you are going to, but it is like there are different school of thoughts for this. I don't know whether in whether among nephrologists also you prefer terminology of membranous glomulopathy or membranous glomerulonephritis. Among pathologists, that
Now
is a
it's called
difference.
membranous nephropathy, actually.
Nephropathy, yeah.
It's
Okay,
called membranous nephropathy for
okay,
nephrologists.
okay.
Again, on the same thing, there is no eye test there.
Yeah, there is no eye test there. Yeah. So,
But
ma'am,
no
yeah,
evident reason for secondary in this woman. Right?
yes,
Well, no
ma'am.
hepatitis B, C, no lupus. So all that serology was negative.
Okay.
Serum PLA2R was also negative. If you do it, that was also negative. So
Ma'am,
anyways,
I have a feeling that, see, ma'am, when I see these class 5 lupus now, ma'am, majority of these cases, as I've told you, 60% will not show full house IF pattern. The other thing is, majority
we're
of these
reaching
patients
forward into full blown.
will have normal complement levels also. Okay. DSGNA is mostly negative. Okay. ANA, I'm not sure, ma'am. ANA, if ANA was also negative.
Non-specific, what do we do with it if
Uh,
it's
but
positive?
ma'am, I'm sure if you follow up this patient for next 5-10 years, now she may develop a full blown lupus. Now
Yeah,
also,
even
why
rates are
she,
negative also.
ma'am? Now also she has some joint pains and all that findings clinically
Hardly
described.
any.
Okay, okay. But ma'am, this is the morphology and overall is favoring more
Yeah,
secondary than primary. If you look at,
agree with that. Anyway, we've given her treatment. Let's see what she does.
okay.
How she does, rather.
So we come to the next case, ma'am.
Right.
Ashuru BP Tastu Nova. So this is 66-year-old female, known case of diabetes for 15 years, hypertension for 30 years, presented with increased creatinine 4.5 milligram, urine protein 3 plus, RBC 4 to 6, no evidence of retinopathy, normal kidney, chronic kidney disease, diabetic nephropathy, Fsgs. So, ma'am, majority of the cases of diabetes, long-standing diabetes, I get this history that there is a sudden rise in serum creatinine. It was like 1 month back, it was 2 or maybe 1, and now it is like it has increased to 4.5 or 5 and all that stuff. And the findings what I see in majority of these cases is there will be diffuse diabetic nephropathy or diffuse glomerulonephrosis, and there is significant tubular interstitial chronicity. So in this case, when you look at this biopsy, these are the broad hyaline casts. The moment I see broad hyaline casts in a kidney biopsy, I know that this is a chronic kind of a thing. Okay. So there were, look at this. So these are the broad hyaline casts which are there. This is thyroidization of tubules, the small casts, and these are the broad hyaline casts. So presence of broad hyaline cast means it is a chronic kind of disease. There is lot of tubular atrophy, interstitial fibrosis. In those areas of tubular atrophy, you can see some inflammation, but if you see inflammation in the non-atrophic areas, then it is significant. If you see inflammation which is minimal in the, if like in this, in these areas, you hardly see any inflammation. But if you look at the glomuli, there are 4 glomuli. There may be 5 glomuli: 1, 2, 3, 4, and 5. Out of 5 glomuli, 4 are globally sclerosed. And when you see extensive hyalinosis in a glomerulus, that also is mostly that commonly is seen in diabetes and hypertension. And I always feel it is a combination of diabetes and hypertension which causes this kind of a morphology. It is not isolated diabetes is causing or isolated hypertension is causing this. So what we can see here is out of 5 glomuli, 4 are globally sclerosed. There is one glomerulus which is left, which is showing some mesangial expansion, some thickening of the capillary loops. You can appreciate here, you can see a tubular atrophy, significant wrinkling of the tubular basement membrane, and there is hardly any tubular lumen you can see. You can see a small tubular lumen here, but no lumen here. That means these are all atrophic tubules. So when I was talking about the hyalinosis, you can see this kind of a pink glassy substance which gets deposited whenever there is glomerulonephrosis, and this mostly is seen with diabetes and hypertension. So vessels are also thick walled. You can see small arterioles which are thick walled. Another view to highlight that there is extensive hyalinosis of globally sclerosed glomerulus. These are ischemically wrinkled tubules. This tubule is showing what we labeled as a, this tubule is showing a thyroidization of tubule, and this tubule is showing endocrinization pattern. So endocrinization pattern is mostly seen with ischemic injury. So hypertension, renal vascular occlusion, and all that. This vessel is showing a hyperplastic arteriopathy. So you can see the, this is the intima, and the media is showing onion skinning. So when you see onion skinning of the vessel, that is called as hyperplastic arteriopathy. That is commonly seen with hypertension, chronic TMA, And if there is a scleroderma crisis, you can find those kind of things. You can find this kind of hyperplastic arteriopathy in these. So this also suggests that it is a uncontrolled hypertension which is causing all these things. Then, if you look at the glomeruli, there is minimal thickening of the glomerular capillary wall, which can occur in hypertension and diabetes. There is mesangial expansion, which is commonly seen in diabetes than hypertension. But yes, if more than 90% glomeruli is sclerosed, I am hardly left with any viable glomeruli to look at the morphology. This is a Mason's trichome stain that to highlight that there was ischemically wrinkled glomeruli also. So you can see this Mason trichome stain, which shows that the Bowman's capsule is significantly thickened and wrinkled. It is showing wrinkling. It is like this wrinkled, and the capillary loops. There is expansion of the urinary space. Okay, and there is ischemic wrinkling. We have to remember, as this is for pathologists, that whenever a glomerulus is ischemically wrinkled, it will show some duplication. So many times in transplant biopsies, if there are ischemically wrinkled glomeruli, they are interpreted as transplant glomerulopathy, which is not correct. So this is, you have to see if the glomerulus is showing expansion of the urinary space, that means it is a ischemically wrinkled glomeruli. You don't interpret duplication in these ischemically wrinkled glomeruli. So this also suggests that this is a ischemic insult also is playing a role in causing the pathology here. Yes, in addition to all that, there was occasional tubule which was showing granulocytic cast. So if I see occasional tubule with granulocytic cast, I don't label that as acute pyelonephritis. Or so many times we see cases, and these diabetic patients are prone for urinary infections, and they can get them. The only thing is, if I find significant number of tubules with granulocytic cast, I label that as active kind of pyelonephritis component which could be going on. But when I see occasional tubule with apoptotic or these kind of granulocytic cast, I label that this could be result of a resolving infection also. Okay. So I always say that you can correlate with microbiological studies. But yes, when I look at this biopsy, it is like a gone kidney. Okay. So look at this vessel. So the intima, and this is also a very bad prognostic sign. This is the intima. Normally intima sits on the media. So what is happening here is intima, look at the intimal thickness. It is more than medial thickness, or maybe equal to the medial thickness if you see here. And this, when the intima is more thicker than media, that is also not a good sign. And that happens with very chronic hypertension. It will not happen with acute hypertension. This will happen if the hypertension is uncontrolled for maybe 5 years or 10 years. It will not happen for in a short duration hypertension. So all these findings suggest that it is a combination of, though many times we say label it as only diabetic nephropathy, and many times I say diabetic nephropathy with arterial nephrosclerosis. So what I mean is it is a combination of hypertension and diabetes causing that. So this is just this is Mason's trichome stain highlighting all the globally sclerosed glomeruli, and all that blue stuff is all tubular atrophy and fibrosis. So there is hardly any non-scarred cortex left. So practically it was like I am very gentle in saying it is like 50 to 55% IFTA, but actually speaking, it is like 70 to 75% kidney is gone. So it is diabetic nephropathy class 4 with presence of that occasional granulocytic cast. Yeah. So these patients, man, like once it is like class 4 diabetes, and clinically also you feel like that, so you plan for transplant and all that stuff, and they
That's
come.
So we tell them nothing can be done.
Okay.
We call it a fried kidney. At least I call it a fried kidney.
Yeah, that's it. Yes, ma'am. I have heard that word from you when you look at these transplant biopsies also, which
Yeah.
are like gone.
It used to be American terminology. Fried kidney means no kidney.
Okay, ma'am. So this is the, now next case is the last case, ma'am. Partha Kalita. So 42-year male with history of hypertension for 6 years. Complains of cola colored urine occasionally. Urine routine microscopy show 3 plus protein, RBC is nil. Urine PCR is 1.8. You thought of IgA nephropathy, MPGN. Okay, most likely IgA nephropathy because there was history of cola colored urine, and MPGN also because you thought that there was some activity going on. But the present microscopy showed no RBCs in the urine. So if you look at these glomeruli, there is one glomerulus which is globally sclerosed, and just compare the size of this glomerulus with this glomerulus. This is a big glomerulus, and that you see, and this is a hilum. This is a renal hilum here. Okay, so you don't see any proliferation. There are some RBCs in the glomerular capillary loops. There is no definite thickening. I comment on thickening on the PS10, but Yes, there is no significant thickening of the capillary wall. There is no endocapillary. There are no crescents. So there is no mesangial hypercellularity. So on morphology, we have excluded that this is unlikely to be IgA. This is not showing any duplication. This is not showing any endocapillary. This is not showing any lobular accentuation. So we have ruled out on morphology. This is unlikely that this will be a MPGN also. But yes, the immunofluorescence is also going to help us. If immunofluorescence is negative, that further confirms that we have excluded IgA and MPGN. So practically speaking, this biopsy showed few globally sclerosed glomeruli, some compensatory enlargement of the glomeruli. This is a PS chain which shows this globally sclerosed glomerulus, and Bowman's capsule which shows ischemic wrinkling. And similarly, this is the same glomerulus which I showed you on the H&D stain, where there is thickening of the Bowman's capsule. You can see thickened Bowman's capsule, and then it is fine. Thickened Bowman's capsule, then it is fine. Again thickened. So this happens when there is a periglomerular fibrosis which has started. And whenever there is a periglomerular fibrosis which is there in a glomerulus, that means that glomerulus is progressing towards a dead glomerulus kind of a state. Okay. So a glomerulus which has got a significant periglomerular fibrosis, so actually speaking, it is not actively participating in the kidney function. Okay. So, and the dominant finding was majority of the vessels, they were showing this kind of a hyalinosis. So there was hyalinosis, there was few globally sclerosed glomeruli, some glomeruli with periglomerular fibrosis. So looking at the vascular changes with a history of hypertension also, and proteinuria, which is like 1.8 grams, not significant. So I thought that we can explain everything by hypertensive nephrostenosis. But yes, the important thing is in these cases, there is significant role of microscopy, because the lab microscopy showed that the foot processes, if you see, look at these foot processes, these projections, they are, and just compare these projections with this area. So in this area, there is some focal foot process effacement, but majority of the capillary loop, like in this image also, 70% of the capillary loops are showing preserved foot processes. There is only focally 25% area, this area, which is showing a foot process effacement. So whenever we interpret foot process effacement, we never look at the capillary loops towards the mesangium. We look at the capillary loops which are at the peripheral location, away from the mesangium. So you have to see the capillary loops. This is a mesangial area. So in this mesangial area, there could be some foot process effacement. So you see in the free capillary loops away from this mesangial area. Okay. So there is no foot process effacement. So I think we can explain everything by hypertension. I'm sorry, I didn't click that Fsgs lesion. There was one segmental sclerosis lesion also. Yes, okay, the report says there are 16 glomeruli. One is globally sclerosed. The non-sclerosed glomeruli show compensating enlargement, which I've shown. There are few glomeruli with periglomerular fibrosis. Okay, no segmental sclerosis. And so this, by mistake, I've written FSGS. It was only hypertensive nephrosclerosis. So since there was some ischemically wrinkled glomeruli, vascular changes, and some periglomerular fibrosis, and subnephrotic proteinuria, I labeled this as hypertensive nephrosclerosis. And even EM also, it correlates that there is only a minimal foot process effacement. So that rules out a primary podocytopenia. So we can explain everything by hypertension. Okay, ma'am. So this was the last case.
This was the last.
Yeah. Yes,
so,
ma'am.
One kid biopsy, I think we'll send it to you again.
Okay.
Somebody called Momin.
Okay.
So,
okay. I think I must have missed that.
Yeah.
So what was, so maybe next time we'll discuss.
Yeah.
Yeah.
So I'm forwarding it to you right now.
Okay, ma'am. Okay.
So next time we'll incorporate that.
Yes, yes. Next
that
time
biopsy came out of a focal scar, it seems.
Okay. Okay.
So
I don't remember, ma'am, but I'll have a look. So next time next time we'll discuss that.
Next time we can do that. Should I mail it to you? WhatsApp it to you? Easier.
Ma'am, WhatsApp.
Okay,
yeah.
Sure.
Okay.
Done it as we speak.
Okay, ma'am.
All right.
Okay, ma'am. So if there are any things you want,
any queries, anyone? No, this was good, Rajan. I think.
Yeah.
So I think we kind of went over our biopsies. If you have some interesting ones, we can have another class.
Yeah.
And you can kind of pick up those interesting ones and go on with them.
Surely, ma'am. Surely. Surely. So, yeah. So next time also, if you want this, maybe in a month we can do
Yeah,
twice a
in
month,
a month.
whatever. Yeah.
Otherwise overdose हो जाएगा. सुना है आज
Overdose हो
शाम
जाएगा.
को भी पढ़ा रहे हो आप.
आज इवनिंग में भी I have a class. ठीक है मैम.
ठीक. चलो. Thanks a
Okay,
lot.
ma'am. Okay, ma'am. Bye.
Thank you.
Bye.
This was
Thank
Thank
you,
you,
really.
ma'am.
Puneet.
Thank you, sir.
Thank you, Puneet.
Thank you, Puneet.
My pleasure, ma'am. Thank you.
Bye. Read questions.